All right. So how about we go ahead and start? I want to welcome everybody to the last year of 2022's Virtual Global Spine Conference. I'm absolutely honored and pleasured to have one of my good friends, colleagues, and mentors, Dr. Arthur Jenkins from the Mount Sinai School of Medicine. Dr. Jenkins and I have probably known each other close to probably over 10 years. He's known me ever since my residency and fellowship. He's one of the people who's instrumental to getting me interested in spine surgery and teaching me many of the things I know and a lot of the approaches I take towards my patients. Dr. Jenkins is an associate clinical professor of neurosurgery and orthopedic surgery at Mount Sinai, and he's the CEO of Jenkins Neurospine as well too. Today he's going to be speaking about one of his passions and one of my passions, and that's spinal metastatic disease. And without further ado, Dr. Jenkins.
Well, thank you, Jonathan. It's an honor to be here. This is I like trying to keep my work as much fun as possible, and this sounds like a really fun group to be involved with. First of all, let me just tell you, as far as conflict of interest, I do own a spine tumor related patent. I am a less than 1% minority shareholder of Synchron. It has nothing to do with today's talk, but I do like saying that. And I am a spine surgeon, so I get paid to operate on tumors. So that is a potential conflict of interest. A little bit about me, like who does he think he is talking about tumors? I actually did my neurosurgery residency, graduated in 2000 from Mount Sinai. My mentors there were people like Cal Post, Noel Perrin, and Narayan Sundaresan, as well as Chandra Sen. Now, Chandra was not a spine person, but he was a skull-based tumor person. And I learned many, many things at midnight from all of these people. And they were all formative in how I got to where I am now, for better or for worse. I then went off and did a year of, shall we say, finishing school at this little Boston hospital under a truly gifted and talented spine surgeon, Eric Woodard. He was one of Sanford Larson's last fellows. So he is from that long, august line of really old school, but really by the books, learning all the lessons, AO spine rules, and really teaching me through all the cases that he did at the Dana-Farber when he was both head of spine and he was the spine surgeon for the Dana-Farber's cancer cases. So we did a lot of big back whacks in our day. I then went to Mount Sinai, where I was full-time faculty until 2018. At the time, just to, flex a little, I was the director of the spine tumor program, as well as the minimally invasive spine program. They might seem to be contradictory, but we're going to get to that in a minute. We're going to link all this together. I then went into private practice, which for me is a little bit more of a private academic environment. I have always believed that our clinical practice should be research guided and that the research should be of clinical value. So we're talking about spine tumors, and specifically metastatic spine tumors, not talking about any of the other stuff. That's a topic for another day. But we're talking about the tumors that either spread by local invasion from another regional tumor or hematological spread via bone into the bone epidural space or into the parenchyma of the bone itself. So what are these treatment options? Well, we know, this is not, a talk to the lay people. This is that all of these different treatment options are available. And as we know, in most cases, it's going to be multiple of these simultaneously or one sequentially. So it's not just which one of these do you choose, but which ones of these are you going to use for your patient. Now, these treatment principles, I try to break it down. The oncologic outcome, the treatment of the cancer itself on a global human body scale, is determined by the pathology, and their medical outcome is determined by the degree of dissemination, their tolerance of the different treatments that we're going to give them, and then their survival is determined by the above two. Now, their neurologic outcome is often very different, and that's determined by the compression of the spinal cord and nerve. So these are things that we as our spine surgeons need to intervene on and keep in mind the other two. So what impacts on the choice of our treatment options? Well, it's partly the natural history of the disease. After all, if somebody has a relatively benign progressive disease, for example, prostate, breast cancer are far more manageable medically than they used to be. I'm old. I'm older than I look. And so I remember the days when we really had very few treatment options, and now there are so many they're advertising on TV. As far as the morbidity, now that's what I refer to as things we know are going to happen. It's a relatively morbid procedure. These things will happen to you, as well as the risk for complications, things that could happen. They're not 100%, but they can, and if they do, they may, send this train off the rails. So this is a talk about lessons learned. So what are they? So the first two things I want to say are more philosophy related. Don't be dogma driven. Just because even some very esteemed gray-haired people told you something doesn't mean it's so. Be evidence-based. And when all else fails, follow the rules. And Jonathan, I'm sure you will remember these. Rule number 1, don't struggle. Rule number 2, everything works in theory. Rule number 3, everything takes more than 5 minutes. Everything's easier from the attending side of the case. Corollary to that one is if you know what you're doing, you can make anything look easy. And rule number 5, when the case is done, close. So with that in mind, as far as spine tumors, especially for metastatic disease, one of the things I learned early on is there's a lot of bravado in spine surgery. There's a lot of, I can do bigger than you can. I can do bigger than this guy. And that's not always in the patient's best interest. The next is that you need to understand that the patient's survival, which is what determines your balance of treatments, is actually important to understand when you choose the individual treatments. If the patient has a really short survival, you're not going to put him through a back, front, back. He's not going to live long enough to see any benefit from that. And then finally, spine mets don't kill patients, but spine surgeons can. And so it's important to refine your technique and focus on all the different ways that you can make sure you do the best job you can for every individual patient. I call this the bravado reduction program. And initially, this is going back more than 20 years, we used to treat solitary mets like they were primary tumors, like they could be cured. And we now know that's really not the case. These are disseminated disease with one focal area that may catch our eye now. But we really shouldn't treat them like we can truly get for metastatic disease, oncologic resections, because there's always another nidus somewhere until they've been fully managed by the medical aspects. And of course, there's the bigger is better. Well, if you can do a front back, I can do a back front back. And is that necessarily better? I'm not so sure. It really depends. And to me, it always comes down to, would you really recommend that you do this particular operation that you're proposing on a family member you actually like? Okay. We all have those family members, but in particular, is this something you would have done? Is this something that you would have somebody you care about have done? So here's an example. Early in my practice, T12 thyroid met, primarily within the vertebral body, about 70% of the body, did not extend out beyond that. Perfect case for a guy who's a couple of years out of fellowship. He's starting to think he's getting good at this. So we did a 3-stage. We did a back to release the posterior elements, remove the non-involved posterior elements, cut it all the way back to the pedicles. Then we did a front transdiaphragmatic vertebrectomy, put in a carbon fiber cage, one of the first ones available, packed it with some cement. Actually, these had to be stacked because we didn't have them any bigger than that. And then did the back, did great. Fantastic outcome. Look at that. I mean, that's looking pretty hot. Well, until you follow him for a couple of years. He develops a chest wall diaphragmatic hernia. He develops a non-union and loose screws because he didn't actually fuse. And then actually he popped up tumor elsewhere. So there's that. So one of the things that got me into this very early was saying, well, what's the evidence and what's on decision making on who is going to live long and who's not? And one of the things we found is that the presence of spinal mets actually doesn't negatively impact on survival in this day and age. Now, 20, 30, 40, 50 years ago, when most of the tumor survival indices that we know about were initially proposed, that might have been the case. But today, with all of the different, the multiple different classes of drugs for chemotherapy, radiation therapy, immunotherapy, different types of stereotactic and non-stereotactic radiosurgery, it's just boggles the mind, all the different options. And so we published this new predictive index for trying to predict survival for patients. And I thought the most important thing to look at is what's generalizable. What's their exam before I touch them? How can that be their exam and their studies? Can that predict how they do? Well, here are two of the most commonly used scales other than ours. And ours hasn't been fully adopted yet, but we're working on it. And you can see all the different factors that go into the different categories that you have to analyze to figure out, well, what's their survival going to be? And so we looked at a lot of different things, including, are there individual organs that if those are also involved with tumor, that it has a negative impact? How is their ambulation? How is that, does the amount that they get around have an impact? And we found that actually it does. In fact, the most powerful impact was the amount of lung metastasis that the patient had, what the total burden of tumor in their lung. And that makes a lot of sense because the quality of the patient's lungs has such a huge impact upon how they do post-op, intra-op, and in terms of survival. After all, we'll transplant just about any organ with cancer in it, except the lungs. All right. So it is the one area that is truly a game changer. And so we found that of all the different things that could have impact, and this is looking at diffuse bony involvement, brain involvement, spine, vascular, and as well as others, and nothing predicted outcome like the lung tumor burden, but the patient's ability to walk before, and we look before rather than after, and we'll get to after a little bit down the road. But if you were, this is a score where 0 is great and 9 is profoundly dysfunctional. And so the higher number is worse, lower number is better. And so in that particular case, so we have a low is better score here, and then we came up with our own general low is better tumor burden score here. And this Hauser Ambulation Index validated in the MS literature for years. So we thought it was a good way to drop in and get a quick assessment of how functional they are. If they need bilateral support, or if they use a wheelchair on occasion, they're really not getting around easily. Whereas if you've got a cane or a crutch, but you can walk pretty quickly, you're still pretty active. And so if you put these two together, we came up with where you multiply the lung tumor burden score by 4 because it was so much more powerful. You really want to overweight that one, plus the Hauser index. That gave you what we called the Jenkins survival index. And what we found is even comparing it to other indices, as well as the Charleston Comorbidity Index, looking at what type of tumor they had just in general, this combination index was the most powerful at predicting patient survival. And here is ours compared to the Tokuhashi and the Tomita scale, looking, and you want the area, maximum area under the curve. You want this gives you the fewest false positive, false negatives. Now that we figured out, one, what their survival probability is, so we can now tailor the treatment to their likely ability to tolerate a big or a small procedure, let's look at what we can do to reduce the risks of what we do. Now, as spine surgeons, we all have it. When we sit there in a dark room, we all have a little graveyard in our minds of all the people who, through the best of intentions and the best of techniques and training, have still had not such a great outcome. And if you don't have this as a spine surgeon, you're dangerous. So what we all think about, how can we avoid complications? And what I found for metastatic tumors, these are the 4 biggest areas where you can change the game. Stage your big procedures. Focus on reducing the OR time and the bleeding. Use paramedian flaps wherever possible. And if possible, if it's an appropriate candidate, use minimally invasive surgical approaches. Now let's talk about what's the importance of staging big procedures. Well, let's face it. You got to ask yourself, how long is it really going to take me to do this at my hospital, at the hospital where I'm going to do it? It's one thing to say, yeah, at the big hospital, they can do this case in X amount of time. But if you're doing it at the small community hospital with the team that hasn't done it before, or if you're not getting to this case because it's an add-on until 7 p.m. and you're going to get the night float team that maybe does mostly GYN, that's going to have a negative impact upon you doing a really big case. Now, rule number 2, if everything works in theory, what time is that start time going to be? Who's going to be around when the case is closing? How long is it going to take them to get that A-line? How long is it going to take them to get them intubated? So if you can ask yourself, now that I've decided what I think they need, how can I break it up into smaller pieces? Can I split up the anterior and the posterior? Can I do a lateral instead of a big anterior to get a less invasive way of doing this? Ask yourself honestly, what resources do I need? Like, how much blood will I need? What reps will I need? What exposure surgeon will I need? You've got to plan all these things ahead of time and make sure that they all show up, because the longer you're fumbling for stuff in the OR, the longer the patient's lying on the table, being exposed to anesthesia, getting colder and having other issues. So what I found is that patients recover much better from 2 smaller procedures and 1 big procedure, because usually you can get caught up in between. You can get the volume back. You can replace the blood products that have been lost. You can get them, you're not on the ventilator quite as long. You're less likely to have transfusion-mediated lung reaction or ventilator-related pneumonias if you break it up. And finally, there's a lot of times you feel the need. I only have 1 block of time I can do this. But then the onus is on you to get that second time to do the second stage procedure, rather than force the patient to have a bigger procedure than they might survive. And my little memory box goes off. And there are tons of times where I think starting a case at 7 o'clock at night, not in the patient's best interest. The next issue is, what can I do to focus on reducing the OR time and the bleeding once I'm in there? And so most of these patients will have some more advanced disease. They're not going to be healthy. So you got to make sure you know what their liver functions are. Make sure you fix these things preoperatively. So you then also got to do other pre-op treatments to reduce the scope or the complications of the procedures. And then what intraoperative technology or techniques can I do to reduce the time and the bleeding? Because the bleeding is what gets you in trouble. And all the other things wind up spinning around into that fundamentally. There are other issues. The longer the wound is open, the greater the chances of infection. There are things you can do to mitigate that too. But the majority of things for spine tumors, it comes down to the bleeding. So as far as the pre-surgical prep, one of the things I've found is that embolization is such a critical part of reducing the intraoperative blood loss. It's a very low-risk procedure, especially if you've got a good team. If you don't have a good team, then maybe you want to get it to a place where they have a good team. Pre-op stereotactic radiosurgery, especially if you can do it up to a month in advance, can significantly reduce the intraoperative bleeding. I've done cases where we've done SRS, the tumor has shrunk a little bit. They're still unstable because the SRS doesn't build bone density. It obviously is going to undermine it. But you go in and it's almost bloodless. So if you can pre-operatively stage it, you're going to thank me for that one. Induction chemotherapy. Hey, if you can shrink that tumor down, pull it away from the bone edges, it's going to make your surgery a whole lot easier. Not to mention, you maybe even reduce how much you have to do. Intraoperatively, hemostasis, hemostasis, hemostasis. But to that effect, temperature is such a critical part. I mean, so many of these big open cases, they are losing heat at the same time they're losing blood. And as your temperature starts to head towards 33 degrees, even at 35, you're definitely getting coagulopathic. So be on the anesthesia team to make sure they are using, if they need to, heated blood, a heated line, using warm the irrigation, cover as much of the patient. I sometimes will use 2 separate bear huggers. We're heating areas around, one under and one over, say over the legs, or I'll make them put one on the arms and one on the legs, and they've got 2 going in the room at the same time. Definitely, as long as it's both indicated and there aren't contraindications, use TXA. It will reduce your bleeding intraoperatively. I like the Aquamantis. That's a brand. I don't have any skin in the game there, but that's one that I like. It's just get the hemostasis, and it's irrigating, it's cooling on the tissue, very effective at reducing the amount of bleeding you have. From a cost perspective, if the amount of time you spend chasing bleeding is more than, say, 8 to 10 to 15 minutes, okay, and on a big case, you could spend a lot more than that chasing your bleeding. This type of thing will actually pay for itself by reducing the amount of cost your hospital has for keeping the OR open on one case. Use cell saver on the part of the case that does not have tumor in it. So even sometimes they'll have filters that they can use to filter off tumor. I have found that patients who get a liter of cell saver versus a liter of packed cells, they do so much better. They have fewer transfusion mediated issues, less lung injury. Give them their own blood at wherever possible. And then maybe when you get into the tumor, pull the cell saver back and then put it back in again when you're thinking about closing. And then get on, you've got to be a partner and an aggressive one with the anesthesia team to give factors early. Don't wait until the blood's pouring out like water. Get on them early. It's like if you think you've got 500 cc's of EBL, transfuse platelets, transfuse plasma, transfuse whatever you need to do. Don't get behind, stay ahead. Now, here's a little something that I learned back from my fellowship director, the case for paramedian flaps. What's a paramedian flap? Well, it's a flap that's off the midline. Now, we're used to, as spine surgeons, doing midline incisions for very good reasons. It's an avascular plane. It's centered on the pathology, and it's symmetrical. It's great. Why would you not do a midline incision? All of the same things that we just said are all the reasons why you should never do a midline incision on a tumor case. It's an avascular plane, which means it won't heal as well as a more vascularized plane. And it's centered on the pathology. It's actually nice to have a big myocutaneous flap over the closure so that the spinous processes or the hardware doesn't stick up and put the incision itself under more tension. So just to make that point, what happens when you make a midline incision on a tumor case? Well, these are tumors. There's a good chance they're going to get radiated, and the radiation, if it's wide field, if it's not stereotactic radiation, if it's LINAC-based radiation, they're going to radiate the field on about 2 inches on either side of your skin incision, as well as your skin incision itself. In fact, The patient may have already had this done once, and this is a recurrence into an area previously radiated. And that means that you're radiating tissue that you need to heal, or you're operating an area that has already impaired integrity. So understanding that the vascularity comes in from the outside edge. Now, these are large vessels. They don't usually close down as a result of radiation. And then they come in from the outside towards the middle. This is a patient, and you can, if you look closely, you can actually see the peau d'orange of this person's prior radiation. And if you made your incision here, you're far more likely, and I'll show you in a minute how much more likely, to have wound problems if you don't park the incision well outside of it. This is a thoracic case. This is first the trapezius muscle that we actually transect. We go through it, and then we tag the edges so that we can approximate the exact point to point at the end of the case. And here is where the incision, the midline, would be on this patient. So looking here at the schematics above, this is the axial view of what we're doing here. You go straight down to the lumbar dorsal fascia, and then head medially, and then start rotating it up and across. These clamps are on the soft tissue underneath, not on the skin edge itself. They're actually at this point here rather than on the skin edge itself. And then once you get down to the spinous process, assuming you still have one, or that hasn't been eroded or previously removed, then you come down on both sides and fillet it open just like any other midline incision. So you can absolutely get the same exposure you're used to without having your incision be right in the most tenuous part of the field. And doing this was shown in this is internal data. We actually never got around to publishing it, but a 25% wound complication rate, that's breakdown plus infection, down to 5%. And that is game changing. And those of you who do a lot of spine tumors know what I mean, that it's really 25%, even in this modern age, for big spine tumors, not unreasonable. Now, the last area that I think makes a big difference in outcomes are minimally invasive treatments for the right patient. Now, I'm a philosophical guy, and so I always consider on every patient, what's the most I can do for them that does the least to them, but still gets the job done. And so when we look at surgery, we do decompressions, and we do, when necessary, some form of stabilization. All right, we do decompressions when there is compression, and we do stabilizations when there's instability. So once again, getting back to what are the expected and unexpected but possible consequences of what we do, we really have to think about what can we do that will reduce the complications as much as possible, as well as reduce the morbidity. What are we doing to the patient? How much long is it going to take them to recover from this procedure? So, of course, we all know why we do decompressions when there's tumor or a fracture from the tumor compressing a neurologic element. And we do it as urgently as we can, because the longer that goes on, the more likely a deficit is to become permanent. So we also want to do separation surgery to protect the spinal cord or cauda equina from radiation. Let's say we're going to do stereotactic radiosurgery. We want to push the center of the residual tumor as far from the neural elements as possible. The neural elements are highly sensitive, and they are the single rate-limiting step on how much radiation you can deliver. And in general, cytoreduction is good for outcomes when you're trying to reduce, let's say the spine met is the biggest bulky one. It's going to make it a lot easier to treat that if you don't have a large nidus that may be protected from chemotherapy. Now, these are just some examples of the instrumentation that we're used to using. And these range from, old school Lukey type constructs to modern percutaneous techniques. But do we really even need that on every spine tumor case? And this is where I want you all to think very critically about what you do in what I'm going to tell you. You're going to do both, but I want you to think very critically about what you do. What could you cut out and still have the same outcome if you could take out the tumor and provide some additional stability if necessary with a good outcome? Because ultimately, if it doesn't have a good outcome, don't do it. Without all that hardware and the approach and procedure related issues to put all that stuff in. So is that even a thing? I mean, can you do that? And now I realized a long time ago that more than half of the tissue that we take out is due to just getting to the tumor, right? Doing a big open procedure, if the tumor's on the other side of you, you got to take out everything between you and the tumor. But what if we could get down to the anterior tumor without removing the rib, the transverse process, the facet, contralateral lamina, or even the spinous process in the midline? What about that? And wouldn't that leave ligaments, bone, muscles, and tendons that provide stability? And maybe we don't need all that hardware. And I will also say, as a little bonus to all the radiologists in the audience, have all that radiographic artifact from all that hardware, which makes it a whole lot easier to image the patients post-operatively for recurrence. So we developed what I call the MUST-D, the minimally invasive, uninstrumented spinal tumor decompression protocol. Now, I use a tubular approach via paramedian approach pathway. And then when we get down into the area where the tumor is, if there's a significant cavity in the vertebral body, we replace it with polymethyl methacrylate and anchor it with a tiny little screw into the bone. I only do this on patients with 1 to 2 levels of disease at 1 or 2 separate and discrete areas. I don't do it if it's more than 2. But you can do this on almost any neurologic status patient, weak or not. And you can do this small procedure on almost any patient. I mean, I've taken some pretty crazy patients and gotten them through, and we'll see how that went. The advantages of this approach are it's a paramedian incision. Remember, I talked about trying to get the incision out of the field. If you come at it from the outside, you can radiate that area, even standard style, and not have it affect the incision. This results in a much smaller operation, which means they usually have a much shorter length of stay, unless your hospital counts against your length of stay, the time when they go 2 or 3 days post-op over to oncology and start their chemo. In which case, sometimes that doesn't shorten their length of stay, but it shortens their time to treatment. And we've seen many patients who start having tumor recurrence. Sometimes in the 6 weeks, we often wait for patients to get chemo after a big incision operation. Short incisions lead to fewer infections. Short operations mean easier for the patient to tolerate, which means more patients can be given an operation like this. Less estimated blood loss means it's easier to tolerate it as well. And smaller incisions and no fusion means that you can start that chemo and radiation immediately. And this can be applied to other, even less invasive modalities than the one I described. And we are putting this together, we're in final manuscript production for this right now. So hopefully this will be submitted in a few weeks. I'm giving you a little bit of a preview on that. But some people will even do this through percutaneous ablations, cement vertebroplasties and kyphoplasties, radiosurgery followed by one or the other. But I like my technique because it gives me visual confirmation of the tumor I've taken out and visual confirmation that the cement I'm packing in is not touching the spinal cord when I'm done. Because if it is, I can drill it back down and make sure that it's not. So is it safe to do this minimally invasive tumor resection? Yes. So you can cut down the skin-to-skin time profoundly. The wheels in, wheels out is not quite as small. And partly, I think I tended to be a little bit more meticulous with all the different modalities I would use. in terms of neurophysiologic monitoring and making sure that we had everything in place like it was a big open operation. But interestingly enough, these patients don't have a loss of Cobb. They don't increase their Cobb angle post-op from kyphosing more, from removing the tumor and not stabilizing. In fact, we actually show a decrease in the Cobb angle. They're actually less kyphotic post-op than pre-op, and even more so if they were significantly focally kyphotic. The spinal canal diameter is increased. So on the post-op imaging, you can clearly see we did a good decompression. And interestingly enough, fewer patients died in the first 30 days who had minimally invasive tumor resection rather than standard open tumor resection for the same size patient, the same type of procedure, or same type of patient and indication. The estimated blood loss, well, we had a mean of 575, but a median of 200 cc's, not even enough to give back cell saver, versus a liter was the mean, and 700 cc's was the median for open procedures. So those are pretty big spectrum. And in fact, I know a few people out there who will stop a case when they get to about a liter of blood loss. And so that may be a little bit, one of the things that are a bias. Is it safe? Do they have complications? Well, if you look at this, only one patient in our series of 44 had any of these major complications, whereas 33% of patients had one or more of these complications. And look at the p-value on that. I mean, it's so small, I can't even see it with my loops. More importantly, does it work? So for neurologically intact patients, the outcomes for doing it minimally invasive and doing it maximally invasive, the same. They have the same preservation of function. But for impaired patients, patients with a Hauser index of greater than 6, remember, or 6 or more actually, patients who need a lot of help to get around, they're not independent. Actually, they do better with the minimally invasive approach than standard surgery. If you look here, their Hauser goes from 7.2 to 7. I mean, it does not change. The p-value is 0.8. Whereas with this minimally invasive approach, they go from a 7 pre-op to a 4. They're actually almost independent on average compared to what they were pre-op. And this is for the patients who are already neurologically impaired pre-op. So that's a pretty significant improvement over standard of care. Now, you look at overall long-term survival, it's not determined by their spine tumor. It's determined by what their original tumor was and whether it was in their lungs. That's something that as spine tumor surgeons, we can't fix. That's up to somebody else. So in summary, evolution of the early days to now, it's more about palliation and preservation of neurologic function than it used to be. Used to be, hey, we're going to do the biggest operation we can because that may help someday. Well, now we know that someday is coming. We're not there. We also know that complication mitigation is critical to having a good surgical outcome. You really got to focus on multiple things during the operation and finding complementary ways to support the patient's recovery with the least invasive and most effective treatments for each patient type. And that means often doing multiple modalities and whatever the least invasive, most effective way of treating is going to be. So, and just one more pitch for the must-do approach: less blood loss, less OR time, earlier chemo and radiation. You don't have a lag before you can start. Less hospital stay if they don't go straight into oncology. And if they do, that's still better for them. Profoundly fewer complications, fewer 30-day deaths, better recovery of lost function. And you can do it on sicker patients because it's much less to recover from. Now, let's get some cases on the board. And here's where we're going to open it up to the people watching. Tell me what you do for this. So this is pretty classic. This is, 80-year-old with prostate cancer, fully ambulatory, no problems. A week ago, started having problems. He's also starting to have a little urinary issue. But at 80, they weren't sure if it was maybe related to this prostate, maybe related to and the prostate surgery that he had, but it was getting worse along with his ambulation. Any thoughts? T4 to pelvis. Any volunteers out there?
Dr. Jenkins, I'll chime in a little bit here. This is a very, very common case. I mean, you see this all the time. Usually, what we see in our practice is this patient comes in essentially paraplegic in the emergency room on a Sunday with a horrible MRI and a very, very similar story. Also on Eliquis with every single medical problem in the world, family wants everything done. That's the typical picture here. So I see a couple of T1 post-contrast MRIs. You can see he has diffuse metastatic disease basically all over his spine. This looks like a mid-thoracic image on the sagittal image on the left. It looks like there's circumferential stenosis, as I'm assuming that cut, that axial cut in the middle is showing you right through the most stenotic portion.
Correct.
So I can't tell if there's CSF.
You can actually see right here that there are two foci, and there's a little collection of it here laterally, but there's also a little nidus here centrally, and it does go a little bit into the pedicle here.
Yeah, I would for this kind of case, my go-to, this patient is 80 years old, was fully ambulatory, had a very good MRS score prior to their presentation now, and now I'm assuming they're just having proprioceptive ataxic gait rather than actual motor weakness.
Correct. They're not weak, but they are profoundly unstable.
Yeah. So my go-to, I would do a separation type surgery. I would do a laminectomy. I would try an open. I would do it open. I do a laminectomy. I would just resect all the tumor around the fecal sac, restore CSF flow around the cord. I would just see if there's any overt instability. Likely not. If there was, I would consider vertebroplasty at those levels, and I would call it a day. I would not instrument. My go-to would just be a laminectomy and separation type surgery. I wouldn't do a corpectomy or go after anything in the vertebral body.
Anybody out there think we should throw some screws into this guy?
Arthur,
absolutely. Oh, yeah.
No, you go, Alexander. I mean, the only thing I do, if they do still have some ambulation, they're able to stand up, I do get an erect radiograph just to have a look, because if they're, sometimes you get forward, and if they're really kyphosing, then you might want to look at that. But for me, if there's no major change in alignment, then I'm with JR.
That's a good place to be. So I'll tell you, for this particular case, we actually just popped a metrics tube down, just took out the dorsal and the lateral disease, and let him fly. He had a 1/2-inch incision. He was home in 2 days and ambulating well at 6 months. So not even a full lammy. We just did a hemi-lam under the metrics tube, took out the central nidus by reaching under the spinal laminar junction, and then the more lateral stuff got down, but didn't. This is a guy who's got widely disseminated disease. I didn't want to take away any of his structural stability, because I just didn't want to start him cascading into instability. And I found these patients do great. He actually wound up dying of an MI about 9 months post-op, but had nothing to do with us, because he was actually fully ambulatory, active. I mean, if anything, he got too active. I don't know, but we gave him back his life until something else came for him.
For that patient, would you ever do steroids and radiation only? Would you consider that?
Well, I mean, Patchell certainly, and let's take it around and say now it's this exact same scenario, but he's on Eliquis and he's got strain on his EKG, and he's got, maybe he's got massive amount of tumor in his lungs. There you certainly would, he got steroid and he was still he was weak on the steroids. So this is somebody whose steroids aren't going to be the treatment. But, you know, somebody like that, you might instead turn it around and say, let's do some SRS and do steroids and get him off the, get him off the Eliquis if we can. Maybe we can't. You know, maybe that's the best he's going to get. And you just, you know, you don't want to kill the patient curing his spinal problem. So you got to deal with the patient you have, you can't take a mulligan and invent the patient you wish you had. So here's another patient. Here's another patient, 72-year-old male, 10 out of 10 back pain, male breast cancer. Oh, it's a thing. Profound gait disturbance, only able to walk a few feet. So we gave him steroids. He's clearly unstable here at this level. And we attempted embolization. We got some of the feeding vessels, blocked, but not, wasn't profound. So what do you guys think?
So this is 72. Preoperatively, any major medical comorbid other than the breast cancer, any major medical comorbidities?
Nope.
Severe.
It's actually pretty healthy.
Pretty healthy. Okay, so that looks like he has diffuse metastatic disease in the cervical and thoracic spine. It looks like he has almost a vertebraplana deformity due to essentially a pathologic fracture at T3 with obvious cord compression, cord edema, and kyphosis at that level. So in this case, although you're technically below a transitional point, you're not at T1, C7 T12, you still have significant ventral compression on the cord, and you still, because you have that thoracic kyphosis at the inlet, I don't think a posterior decompression alone would be satisfactory. I would go for the tumor at T3. So my approach here would be, I would do a laminectomy. I would do a costotransverse approach to the vertebral body. I would try to take out as much as I can safely during surgery. Replace that with a corpectomy cage, and I would instrument likely 2 up, 2 down. That's my go-to. Now I know that's not what you did here, but
not necessarily. So what you're describing, and then I'm assuming that I've converted you to, you would do what we call in the business a parascapular approach. Because this is specifically, it's a paramedian at the level of the scapula at this upper cervical thoracic region.
Right, parascapular.
And so, there are a lot more, there's 17 muscles that support the scapula, and half a dozen of them are medial. And so you want to tag as many of them coming around so that they don't get scapular deformity post-op, but you want to take that paramedian approach to get your, since you're going to be doing a vertebrectomy anyway. Jonathan, tell me, you're going to do the vertebrectomy from the front? You're going to do a 2-stage?
I would do it all posterior.
Well, why? Tell me why.
In order to do this from the front, you at T3, you would have to get involved thoracic surgery. You have at T3, you have the great vessels there. You can even see you have the heart in front of you. It's gonna be very difficult to get over there.
All very good things to remember. That was the point I wanted to get to. This T3 is kind of the no-fly zone for doing vertebrectomies from the front. You can do it. It's profoundly morbid.
Yeah,
I can tell you can do it, but I wouldn't, not on this case.
I think I think you and I did this case together during residency. I know that's not I know that's not the answer here, but I'm just curious, Alex, Mike, what would you guys do here?
I would do less than you would do. I would just do a minimal invasive stabilization. In my hands, it is a possible way. It works. I would just do MIS and then a tubular decompression of the lamina. I don't know how many levels have to be decompressed from this T2 sac. I cannot judge it. I don't see the actuals, but I would not go for corpectomy. I think you will not. I think an MIS solution is enough, and you can do some radiation post-op.
Okay. So you would just do Lamy screws and MIS style. What
Yes.
about you, Mike?
Yeah, look, I mean, I think all to me comes down to how chemo radio sensitive that thing's likely to be. And I would probably go along the lines of Alexander and maybe do some PERT carbon fibers and and then take the back off and then reassess and see how it goes. Just a little mini open approach. So, I mean, it's always hard, and without the patient in front of you, the end of the bed test I find is as good as a lot of these scores as to how they look and how aggressive to be. But I've been burnt by doing T3 aggressive corpectomies. I mean, there was one I did in a lady who was in her 40s who's now deceased, and we kept her going for a while. But, at her first surgery, when we were reaching around the front, there was a tiny bit of CSF. We packed that. She did fine for a couple of years. And then when she came back with recurrence in that area, we went back for it again, and there was just CSF everywhere the next time. Like, it was horrible. So, the corpectomy up there is a tough op, right? I'm not, I think in a 70-odd-year-old, you can probably come back and do it later if you had to, if you just use a posterior MIS approach and try your adjuvant treatments. So, yeah, I mean, I use carbon fiber with cement MIS all the time, and it's great. You need to do a mini open decompression, which is along the lines of what Arthur's saying. He's just doing it with a paramedian as well. But yeah.
So
you can see the result here.
this was an old one. This was a
Yeah.
little bit older, but it was also one where, we looked at this and said, really want to be 2 above, 2 below. And then we got in there and the bones were horrible. So we tried putting screws in. If you notice on the pre-op scan, the T4 has signal change in it as well. And then when you actually go out laterally, you see that there's signal change in the other bones, in the pedicles as well. And so, some of the pedicles were very small. So we wound up actually just doing a local Lamy, getting a little 3-point reduction on the table, and then putting in a claw construct below. And this guy actually did great. But his tandem instability never went away completely, but he became independently able to walk again. So this was earlier in my career. I probably now would have done this through the MUST-D, but I would have put a pretty significant amount of cement in there and do the decompression, do the paramedian vertebrectomy in a way that I leave a little bit of a rind of the original bone behind to keep the tumor from the cement from migrating backwards. And then I put a screw above and below to lock it into the adjacent bone. It's a little bit more of the technique than we can get into here, and we're running low on time. So here's case number 3. A little bit of a complicated story. This was somebody who was gotten to by somebody else prior to being sent to me. They did SRS and a cervical percutaneous vertebroplasty, and then they came back with collapse of that cervically, and then they were suddenly, now they have, this is cholangiocarcinoma. Now they've got tumor down low, and they've got pain and weakness in the legs as well. So they've got this up top, and then they've got this down below. Now what are we going to do?
Dr. Jenkins, may I ask you, when was the first diagnosis of this carcinoma? It's a beast. It's a high mortality. If you can't resect it on block, like a Whipple surgery or any severe liver surgery, what do you think? How long will the patient survive?
So this particular patient survived well over a year and a half from her original diagnosis. So she was very lucky. I guess they got it out locally, but didn't get the metastatic disease, the distantly metastatic disease. And so we were kind of playing whack-a-mole with some of her other disease here. So she was actually pretty healthy for a long time. So this SRS was done maybe 2 months prior to getting in to see me for when she came back with these films here. And then we kept
I'm just asking.
Go ahead.
Yeah, I'm just asking because sometimes when we've see these kind of tumors like pancreatic cancer, there is, or esophagus cancer, then we don't do surgery. This cholangiocarcinoma is it's hard to expect. I would just treat the instability in the cervical spine from posterior, and I don't know what was the height of the thoracic lesion. What is T6 or?
I think this is T10.
T10, so below.
So this is 6
Yeah.
up here. So 7, 1, 2, 3. That's about 10.
So for me, it's just minimal invasive stabilization, and the rest should be performed by any chemo, radiation, whatever the tumor is sensitive.
So she got all of the whatever the most advanced at the time. This was probably 10, 15 years ago, maybe 10 years ago. And any other thoughts? Any other suggestions on what to do for this patient who obviously has multiple metastatic lesions of a not very benign overall condition?
Arthur, can I just ask, how are the upper limbs compared to the lower limbs at this point? You know, is that cervical lesion sort of problematic in a dynamic fashion? Because it doesn't look too bad on that lying MRI.
You know, she was actually highly functional. She was more about pain and us more worried about the impending neurologic loss of function. And same thing in the lower back, it was more about pain than it was about neurologic function.
Yeah, I mean, I'm not against, you know, going after that cervical issue here with an anterior approach. I mean, a corpectomy with carbon fiber cage is, you know, pretty reasonable if you're acting early and you can get it to heal. I mean, the question then is if you have to do the back, it's getting a bit more morbid, and do you do something at about that thoracolumbar junction at the same time? I mean, I'd be interested to see if there is some collapse of the thoracolumbar junction on erect imaging. Because that might change my decision-making process there as well. But I'm also not against perc screws and vertebroplasty for that area down there, and go with the carbon fibers these days for that, so we can see what the tumor's doing.
All right. Well, since we're almost out of time, I'm going to show you my punchline. And so for the cervical, we did go from the front, and at the time it was we used metal. This, I'll tell you, the cervical case was bloodless. And there was no viable tumor found. It was just all radiation-induced collapse and necrosis with no bleeding whatsoever. Obviously, you know, this is a patient we're really not anticipating they're going to fuse. So we put some PMMA into the cage and did one unilateral fixation from the back, and she did very well from that. From the lumbar, or sorry, from the thoracic, what we did was a paramedian, you know, more of a costotrans approach. And there was tumor, when we dug a little deeper, so to speak, metaphorically, into what the axial and sagittal reconstruction showed, the tumor went fairly extensively into the vertebral body. It was more than just in the pedicle like it looked. So we wound up resecting about this much of the tumor. And this is PMMA that we parked in the middle of the vertebral body to keep it from collapsing more. And this is her 6 months post-op.
Would you today use percutaneous like ablation with heating, or all these stuff the radiologists, the interventional radiologists are offering? Would you today send the patient to them?
I think the issue there is you're trusting that you're going to do the procedure, and that, first of all, if you just do the ablation, you're going to get collapse. If you just do the vertebroplasty, you're not doing ablation. If you do both combined percutaneously, you're trusting that the cement's not migrating and that you're getting good filling. I can do all of this through a 16 or 18 millimeter tube and see exactly where the cement is going. I can do an intraoperative spin, you know, with one of the many different types of 3D scans, and I can see exactly where my cement is and where it isn't. And I'll tell you that, and let me get to the Oh, actually, I think I did present the results already. We saw in this series that there was no additional kyphosis that developed over time in the series. In fact, actually, sometimes we got them to be less kyphotic at the index level when we did cement vertebroplasties using this technique. And so she did fairly well. Thanks for your attention. I have some references if anybody needs them, but any other questions or thoughts?
Dr. Jenkins, thank you so much. That was awesome. Any questions? I think, Mike, did you have a question or?
Oh, no, I was just going to say that was very, very good. Thank you very much. That was fantastic.
Oh, well, great questions, great thoughts. You know, we all learn from each other, and so I try to think about everything you guys ask me, and I hope I've given you guys some food for thought here.
Yeah.
Thank you very much.
Thank you very much, everybody. That was a fantastic session. I thank you all for joining us for the last session of 2022, and hopefully you guys can all join us for the next Virtual Global Spine in 2023. Have a great holiday and a very happy new year, and we will see you then. Have a great night.
All right, be safe, be well, everyone.